Hi, my name's Amy Drury, and I'm going to be talking to you today about transcatheter aortic valve replacement, which is something I find very interesting and am personally involved with. So, severe aortic valve stenosis, we'll start there, that will lead us into the valve replacement. And severe aortic valve stenosis is defined as narrowing in the aortic heart valve caused by calcium, which in turn causes decreased circulation of oxygenated blood. So what that means is you have 4 heart valves in your heart, and this particular valve is the one that pushes all of the oxygenated blood from your heart to the rest of your body, allowing circulation to all of your vital organs, including your brain, your liver, your kidneys, everything. So, and I did retrieve that from the Encyclopedia of Senior Health, just kind of putting that in layman's terms. And survival in symptomatic patients, symptomatic meaning having symptoms deriving from the aortic valve replacement, these patients typically only live about 2 to 3 years if left untreated. And you can actually learn more about that at the American Association of Nurse Anesthetists. The severe aortic valve stenosis has actually a worse prognosis than many other metastatic cancers, which I learned on newheartvalve.com. I had no idea, but survival rate after 5 years of diagnosis is about 3%, and breast cancer is about 23%. So that's a pretty big difference. So obviously severe aortic valve stenosis is a pretty big deal. So this speech should be relevant because as many as 300,000 people are diagnosed with severe aortic valve stenosis every year. So it's quite a few. I feel that I'm credible to speak today because I do have an associate's degree in nursing, the science of nursing, and I actually have a current career in structural heart nursing with one of our large community hospitals close by. And we are lucky enough to be able to offer transcatheter aortic valve replacement. And I am the nurse that actually does the transcatheter aortic valve replacement with the team. I help with the workup, so I get to see them from beginning to end. So I do the workup, I'm in the procedure, and I'm in the follow-up after. So it's awesome to be able to see people with the symptoms going through the procedure, and then actually to see the difference after. So it's really good. In this speech, I will inform you about the indication and benefits of the Tavr procedure. I will discuss the importance of identifying the symptoms of aortic valve stenosis, which usually leads to the diagnosis, and the options for the valve replacement that don't require open heart surgery. So, indication for Tavr. Diagnose severe aortic valve stenosis by echocardiography. So echocardiography is just an ultrasound of the heart. It can either be done on top of the chest, which is a transthoracic aortic valve, or transthoracic echocardiography, or you can do a transesophageal, which is actually going down the esophagus or your throat with a small probe. You can do it either way. So that leads to the official diagnosis of the aortic valve stenosis. We typically, if it is found that they have aortic valve stenosis, we will follow it every 6 months to a year with periodic echocardiography to see if it does progress. There are different severities from mild, moderate to severe, and you can typically tell if it's progressing by the patient's symptoms. So we'll talk a little bit about that as well. So the symptoms include shortness of breath, dizziness, syncope, which means passing out. A lot of patients don't realize they pass out. They get real lightheaded, fall to the floor, and don't remember if they lost consciousness or not. This is called syncope. Chest pain, and then, of course, sudden cardiac arrest, which can unfortunately happen with this disease as well. And then also, if they are considered high risk for surgical and recovery complications during and after open heart surgery by age and or comorbidities. So it used to be when we first started Tavr in the nation, it was only for high-risk patients. These are very old, very frail patients that would never be a candidate for open heart surgery. This has actually progressed over time in the last 10 years. A few years ago, they started allowing us to do intermediate patients, meaning they're a little bit less sick, not quite as old, and they were FDA requirements were allowing us to do those on intermediate patients. And actually just recently, within the last 6 to 8 months, it is now opened up for low-risk patients. And you can also learn more about that on edwards.com, about the low-risk patients versus intermediate versus the high risk. A little bit about the procedure itself. So you're admitted the day of procedure from home, or if the patient is recurrently in the hospital for heart failure symptoms, we can do it while they're in the hospital, but typically they go home and recover from the hospitalization, come back the day of procedure. It is a minimally invasive technique. Again, this is not an open heart procedure. We're not cutting the chest open, so we admit you the day of. We use sedation, and actually up until just recently, it was always recommended that you use general anesthesia, meaning the patient is completely asleep, and using intubation, which is a tube down the trachea, to help them breathe, which is the anesthesiologist in the room, and they're with us the whole time. So a lot of elderly patients, they don't do very well being intubated and having to be extubated from that. It can cause a lot of other problems and complications. So we've moved more towards MAC or monitored anesthesia care, where they're deeply sedated but breathing on their own. So we have been using that as well. And I did get that information from another article that I had read. And actually we've been using this in our facility as well, which has been great. It's done wonders for our patients. But it's an article that I read about outcomes of Tavr using a minimalistic approach, and it's from the Cardiovascular Revascularization Medicine article or journal. Let's see here. So for the anatomical access site and delivery system, so as far as how we determine we put the valve in, there are different ways we can do that. We do a CAT scan, which shows us the blood vessels from basically the neck to the toes. And those blood vessels, we measure those to see how big they are, how calcified they are, because we can use those to get that valve in to the heart and to the appropriate spot for deployment. Some people, they're real calcified, or too narrow, but the most common approach is transfemoral, which in this picture that I've shown you today is right here. So we'd actually go through that artery down in your groin area, and it's a large sheath that has the device, the heart valve, compressed down inside of it. And we actually can thread it all the way up to the heart. We come over the aorta here and down into the native aorta, or to the native aortic valve of the patient, and we put it right inside that valve space. We can actually balloon this open, and when we do that, we do rapid pacing of the heart. So we have a temporary pacemaker in the heart with a wire, and actually this is my role during the procedure, is I actually rapid pace the heart at 180 beats per minute. And this allows the heart to it sounds strange, but actually allows the heart to be more still. So the pressure in the heart decreases as the heart rate increases. It allows us to do a better placement of the aortic heart valve itself, because we need it to be in the perfect spot to get the best benefit for the patient. So it's actually quite cool and terrifying sometimes, but it's really cool. So recovery, 4 hours of bed rest always, and that's mostly just to recover from sedation, to come out of the anesthesia, and then we walk them shortly after. And that is to get them up moving, to get their lungs re-expanded, to see how their symptoms are, and that really tells us how they're going to do in the recovery period. We also, in immediate recovery, watching for access site bleeding, because we are going through an artery, and it's a large sheath, so we're poking into an artery, whether it's in the groin or in the subclavian, which is up under your neck, or in your neck, which is the carotid. So we watch for access site bleeding, so we monitor that, and the heart rate and rhythm. We monitor that very closely to make sure the patient is not going to need a permanent pacemaker afterwards, because that heart valve can push on your heart's native, the pacemaker center of the heart, where that electroactivity is coming from. Sometimes that can get disrupted and causes the patient to need a permanent pacemaker after. Not real common, but it can happen, so that is one of the risks. Typically discharged home the following day. We usually tell our patients 1 to 2 days after the procedure. The majority of our patients go home the following day. We do close follow-up with the heart valve clinic, 1 week follow-up, 30-day follow-up, and a 1 year. We do heart rate and rhythm monitoring at those follow-ups, as well as ultrasound of the heart to check out that heart valve to make sure everything looks appropriate. We do blood work to make sure kidney function and blood counts are appropriate. And we do very close phone follow-up as well. So we want them to call us with any questions or anything regarding what's going on. So quality of life. So this is the biggest thing. There's significant improvement in all symptoms, especially the shortness of breath and fatigue. And the biggest thing we hear from our patients is that they didn't realize how bad they felt until they had the Tavr. So until they had it fixed, essentially. So they didn't realize how short of breath they were because they become accustomed to it. So that's just their life. And so now that they've had the procedure, they feel amazing. They feel, 15 years younger. So it's really awesome to see. So in this speech, I informed you about the indication of benefits of Tavr. We discussed the indication, the explanation of the procedure, and the recovery process and quality of life as a result. And then also an unfortunate way of the aortic valve stenosis. So it affects more than 2.5 million people over the age of 75. 50% of those people will die within about 2 years if left untreated, if it's not intervened, whether surgically or by the transcatheter aortic valve replacement. So it's really important to be checked if you are having any of those symptoms, especially if it runs in your family, because it can be a genetic. There is what's called a bicuspid aortic valve, where there's only 2 leaflets instead of 3, and so that can be genetic, and you would definitely need to be monitored. But I encourage you to check out newheartvalve.com. There's all kinds of awesome information on there, and thank you for watching.